We are going to start slowly. We have more participants joining us as we speak, but very much welcome to you who have joined us already to this seminar tonight, or this afternoon, or this morning, depending on where you are in the world. The seminar is going to be about politics and diplomacy for health. Something that attracts quite a lot of interest today. It's not enough to have the public health evidence, but we need also to know and understand how we can better navigate successfully in political landscapes, whether they are at the global level, regional level, or in our countries. I'm delighted tonight to have with me both colleagues who are working in other international or other national universities and academic institutions, and also two practitioners who are doing or have been doing or are now on her way to be doing even more of health diplomacy in practice. My name is Anders Nordström. I'm with you from Stockholm in Sweden. I'm today associated with the Stockholm School of Economics and the Karolinska Institute. I used to be the Swedish Global Health Ambassador for 13 years in the Foreign Ministry, and I'm going to share some of my experiences in terms of diplomacy and health. But let me also then, as I said, introduce two colleagues who are with us now from the start. Lindsay Baines from Oxford University in the UK, and Gary Asline from Toronto University in Canada. We'll later be joined, as I said, by two practitioners, former US Ambassador Jimmy Colker, and now Amal Alil is actually joining us here also from Somaliland and Karisha. Very much welcome, Amal.
Thank you.
Program tonight, or this afternoon, I'm saying tonight because it's night here in Stockholm, will have three sessions. We will start with a session around what is health diplomacy, and I will discuss and share some personal thoughts about what is the understanding of health, politics, and diplomacy. And we will also hear from a colleague of me here in Stockholm, Paul Rosenberg, who is working at the Stockholm School of Economics and done some more research to try to understand, again, people's perceptions, but also what is the demand to develop the competences around health diplomacy. And he will share the findings from a number of interviews that we did last year. Then we will have open up for questions. So please, if you have questions, you can already now post them in the Q&A or as you hear us speaking. After that, we will then get to Lindsay and to Gary and hear about two programs that also exist today in terms of how you can develop your skills and competences around health diplomacy. Then we will have a break. And after the break, then we will have and listen and speak to Amal, one of our emerging leaders who participated in our program here in Stockholm some months ago around politics and diplomacy for health, who's working as an advisor to the minister in Somaliland. And then we will also have with us, as I said, Jimmy Colker, former US ambassador, and today an advisor to the State Department in the US. We will start, and I will do this in a slightly different order than what we see here. So we will actually now listen to and hear from Paul Rosenberg on some of the research work that he and some colleagues conducted last year that sets a nice scene in terms of what we are actually now going to speak about. And I'll see whether I can now switch to him. Which is easier said than done. I will try. One second.
Hello, and thank you for hosting me. My name is Paul Rosenbaum. I'm a researcher at the House of Governance and Public Policy at the Stockholm School of Economics. And I'd like to talk to you about some of the work we've done on global health diplomacy, over this past year by explaining the learning, mentoring, and skill development for international politics, leadership, and diplomacy for health. My plan for today is to tell you about the background research we conducted, as well as the data collection that brought us to understand better global health diplomacy and how we put these findings to use to develop a program. Our team began this project last June, and since we're primarily researchers, we started by examining academic literature on global health diplomacy. As you can see, the field has grown substantially over the past 20 years, and it's also grown into many different disciplines, which we explored over several months. A few of the articles that were particularly interesting to us discussed capacity building in health diplomacy. For example, this study, which examined 50 different offerings, showed us that there's a wide variety of formats that allow people to learn about and get training in health diplomacy. Most of these are taught in person and primarily in the US and in Western Europe. We also conducted our own landscape analysis to understand more about the offerings for capacity building. We explored the content of various programs, such as the tuition costs, formats, key faculty, and how they each distinguish themselves. We found that while some claims that there were over 200 offerings available for health diplomacy or capacity building, we also found that it was very difficult to gather information about a majority of these programs. One aspect we particularly focused upon was the participant profile of who these programs were targeted to. These ranged from current university students to specialist field workers or team leaders. Some programs required previous experience, some required previous education in health, and some required none at all. Overall, there was a wide range of profiles sought after, showing that options exist for learning at many different levels of professional and educational experience. It was also interesting to consider the formats of these programs. Some of these were taught over just a few days. Some of these were spread over a few weeks or even many months. After reviewing so much academic literature and studying a variety of existing programs, we decided to collect further data from experts who have worked in the global health diplomacy field for many years, as well as emerging leaders in this field who have considerable experience. Over the span of a few months, we conducted 38 interviews and held 5 focus groups. We were very pleased that we were able to gather this data from a fairly balanced mixture of people working in academia, government, and civil society, as well as a balance of gender and those working in either the global north or the global south. The interviews were each about 1 hour long, and the focus groups were 90 minutes per session. All of these were recorded and transcribed, which gave a total of about 40 hours of data or 662 pages of transcribed text. This data was coded and analyzed, and we turned that into an academic paper, which is under review at a leading journal. I'd now like to share a selection of our learnings, as we wanted to put this information to practical use to design a new program. We classified our reading of the transcripts into 6 main themes: experiences from global health diplomacy, hurdles in practice, future issues and priorities, knowledge management, pedagogic proposals, and potential challenges in delivery. In our first theme, a few things stood out. Our participants came from various professional backgrounds and had diverse experiences and trainings. Many seemed to have stepped into global health after starting their careers in another area. This was in fact seen as an added value due to the necessity to wear many different hats. The need for a clear vision and a long-term vision was emphasized, as well as a human-centric approach of the field. That is, the ability to make things happen by mobilizing people and leveraging relationships. For example, identifying influential figures who played a pivotal role in the decision-making which were often the junior staff who advised the senior decision makers. Furthermore, patience and humility were seen as essential virtues due to the inevitability of trade-offs and compromise to reach end goals. Global health diplomacy involves maneuvering through a complex and ever-changing geopolitical landscape. For many, diverse national interests and priorities were becoming more articulated, making collaboration more complex. We heard that it's often required to take decisions in ambiguous situations, which is no easy task when also required to maintain trust and legitimacy. Additionally, there is the ongoing challenge to keep health issues at a priority even when they're not in the public spotlight, especially during crisis. Also related to the quote on the side is the human factor of emotional strain, a challenge I'm sure we can all relate to. Regarding future issues and priorities, a lot of interesting thoughts came up. We heard an emphasis on providing better training early in careers to build knowledge and ongoing training in mid-career to develop leadership skills when managing people and representing important agendas. Second, we heard a recognition of the interconnection between health issues with other social problems like climate change, economic development, human rights, and security, and the need to better communicate these links. We also heard a lot about the opportunities for digital health and the need for better governance to better employ these tools and limit associated risks. Lastly, we heard that leaders will increasingly need to be ready to step into tough tasks and risks to make positive change at the institutional level. On our fourth theme, knowledge management, we heard that there are multiple ways that must work in unison to manage knowledge effectively in the field. For example, being able to simplify complex information and communicate this in a way that is adapted to and relates to different audiences. Also emphasized was the ability to engage continuously with stakeholders to be up to date on changing agendas and priorities. This also relates to the last point of having an entrepreneurial approach, being able to identify opportunities and turn ideas into action. We also asked openly for suggestions on the pedagogic formats and how we could best design a learning, mentoring, and skills development program for mid-career professionals to become better and more effective global health diplomats. Some of what we heard related to, first and foremost, a need to establish a common understanding of the field. That discussion also flowed into various areas such as the wish to address individual skills development in being able to apply what is learned to real settings. Having a chance to access experienced leaders and hearing their stories of both success and failure was also regarded as something that would bring value to them. Furthermore, the simple thought of having time to sit down together and discuss the heavy topics related to the field was expressed as something missing and needed. Some more practical suggestions regarding methods came up, such as incorporating role play, simulations, and other fun as effective ways to train essential negotiation skills from different angles. There's always a need to look at the potential challenges to delivery. We asked participants about this, and they told us that they often struggle to integrate new knowledge and skills into their regular routines. Accessibility to reach on-site training was also identified, as it can be difficult for many individuals to travel to a program if it's based, for example, here in Sweden. The high cost associated with bringing people from around the world also needs consideration for long-term feasibility, and we were advised to consider holding trainings around other events held in Geneva or New York where potential participants may already be in attendance. Several participants also emphasized the complications arising from the visa process and the tightening of national boundaries, which adds a political dimension to people from around the world gathering in a single location. Lastly, we heard concern about how we should identify and recruit the right people for our program, and while also trying to build capacity for those who may not be selected. As a follow-up, we conducted a questionnaire. It was also interesting for us to see the perspectives of how these different issues were perceived by our respondents, where the most challenging seemed to be making organizational change and aligning partners' agendas. We took this into consideration also in designing our program. All of this helped.
Oh, we'll see whether I can get back here. Thank you. That was Paul's presentation, and I think some of what he shared is valid not just for the program that we're running in Sweden, but also programs that are taking place in other parts of the world, and we will hear from Lindsay and Gary in a few minutes. I will now continue. Now I just need to get the right slide back here. And share a little bit of my own experience from having worked on this now for some years. I'm reasonably good at health and politics, but I'm less good at sharing slides. But I will do my best. So can you see, is the headline now Global Health Diplomacy? Okay, great. Thank you so much. I said my own background is I've been working on global health for more than 30 years. The last 13 years, I was a Swedish health ambassador based in the Foreign Ministry in Sweden. And before that, I worked for WHO and for different agencies and partners across the world in different capacities. If we look into the literature in terms of what do we mean by global health diplomacy, we heard a little bit about the perceptions from Paul that came out of the interviews that we conducted, but they are different. No. All right, here. There are different definitions about that. This is about both improving global health, but also improving international relationships, relating to different kinds of diplomatic activities, focusing quite strictly on the diplomatic work. There is a definition that is widely used today in terms of what is diplomacy. And there is also one definition that I found in another place, which is about that this is about building trust and negotiation and using health then basically as a means for that. My own definition or way of thinking around health diplomacy is about this. That health diplomacy is both the art, but also the science and the means for how we can improve health, by which both governments, private sector, civil society, individuals can act and navigate in political processes, either at global or regional level. So this is in some way where I've landed, and also the program that Paul was referring to that we're running in Stockholm. This is basically what we have used. Another important dimension on this is that what are global health diplomats or health diplomats? Possibly we should drop the word global and speak about health diplomacy and health diplomats. My and our sort of view on this is that you can be a health diplomat even if you're not working in the Ministry of Foreign Affairs and being a formal diplomat. But if you are one of those actors that have an interest in navigating the political landscape to improve health, you can be such an actor whether you work in another part of government, whether you work in private sector, whether you are a civil society actor, or whether you are working also for private sector as well. But a diplomat using then the art, science, and means of diplomacy to improve health. That's my sort of view or sort of understanding of what is a health diplomat. But this is something that is, I would say, still very much discussed, but I think that's a useful way of thinking around what it can be. As I said, my own background, I was working in the Swedish ministry. For me, health diplomacy, I've had the privilege of participating in quite a few global processes during the last 30 years. How we established the Global Fund was an enormous amount of work, but basically diplomacy behind the scenes in order to get there. And here you see the former Secretary General, Kofi Annan, and then the first chairperson of the board of the Global Fund, Crispus Kionga from Uganda. A lot of the skills that they applied was diplomacy in practice.
Anders, sorry, I don't think your slides are moving forward.
They are not moving forward.
Right now I see global health diplomacy with 4 bullet points. And it's not in full mode, screen mode, so.
I see. So let
Sorry
me
to interrupt.
this then. So where are we now? What do you see now?
I see the Lancet.
The Lancet? Okay, so then I need to change here instead. Okay, fine. So then I was saying that the next example of this, which I had a privilege of working on myself, was then the establishment of the Global Fund. Another example of global health diplomacy is, of course, I mean, highest political level. 2006, I was acting Director General for the WHO, and I participated in the G8 meeting in St. Petersburg. That was also a way of actually then trying to convince those high-level leaders that health is important. And I used a message and some tricks to get them to at least got interested for a while. The whole process, how we moved from the MDGs to the SDG, began a political process. A lot of work happened behind the scenes to move from one set of global goals to now a new set of global goals of quite a different nature. A fourth and last example is, again, that I was involved in now during the last years, was the sort of lessons, what came out of the COVID-19 pandemic, and the high-level panel that President Sirleaf and former Prime Minister Helen Clark led, that was called the Independent Panel on Pandemic and Preparedness and Response, with including 11 absolutely fantastic, in some way you can call them health diplomats, but an extremely difficult piece of work. Clear recommendations. The world is still, yes, using diplomatic skills, but negotiating in Geneva right now to see whether we will get a new pandemic treaty. Difficult. So health diplomacy, engaging in health, engaging in political processes, sometimes works, but sometimes don't. But there is a lot, I believe, that we can learn from what works in the political setting and what are the skills that we need to have or to learn or to be inspired by in order to be able to be more successful in political settings. So what are those skills and competencies? Let me spend a few minutes on that. Now you've got all of those at the same time. Okay, we'll skip that. We'll do like this. I was going to take them one at a time. You see all of them now at once. Yes. So basically, those are the 7 skills and competencies that we've been working on now around global health diplomacy in the program that we're running in Sweden. And I'm going to say a couple of words about them one by one. But basically, these are based more on practical experience. How do you actually do it? And if you're going to be successful, what is needed? The first one, understanding who's really taking the decision. To be able to read the political landscape, those are 9 heads of states or heads of governments in a seminar that we run with the independent panel. But are these the ones that are taking the decision? Or is it so that they have political advisors that are the ones that are really basically putting the words and the decision in front of the minister or the president? Understanding who's really taking the decisions. Are the decisions taken in the boardroom or are they taken before the board meeting itself? First important skill to know how to read the political landscape. The next one is, how do you ensure that you have friends? How do you create trust? How do you establish your networks? Everybody is speaking about trust, but how do you actually do it? This is my trick. My trick is having people for dinner diplomacy. To the left here, you have the former president of Chile, Michelle Bachelet. And we were running a board meeting with her here in Stockholm, and we have 70 people cooking as an icebreaker to that board meeting. If there is something people remember from that board meeting, was that evening cooking session where people really connected, made friends, created networks. You can do this in different ways. So of course, this is one way, but the importance of having network and having people you can call and where people that are trusting you and that you can trust is essential. Communication, knowing when to speak, when to communicate, when to put the message on the table, not too early, not too late, but knowing the right time, but also what kind of language, what kind of style, different constituencies, different settings, different styles, and one needs to be cognizant of that. Something we learned, and you heard that from Paul, is also that we have something to learn also from the private sector, entrepreneurship. How are you driving a company today to success? There are many similarities with how we drive to success for a political decision for health. Then if you compare that to the private sector, here I'm sitting with the former president of AstraZeneca and former CEO of Ericsson and Volvo, one of the most sort of senior business leaders in Sweden, and having a chat with the fellows in our program, getting his experience in terms of what is your take on how we can navigate successfully in a political landscape for improving health. Next one, about managing uncertainties. I mean, if you're going to be a successful diplomat, you need to be able to manage uncertainties. I was heading the WHO country office during the Ebola outbreak, and before that I was working with David Nabarro, trying to negotiate and navigate in the political landscape in West Africa. Here we are waiting to see the president of Guinea. Difficult, and you need to be able to have that competence, not knowing everything, not knowing what is going to happen, not knowing what the president is going to say when you are going to face it. And also accepting that sometimes you actually will fail. An important competence and dimension. And the last line, coming back to this picture, leadership. Identifying leaders that are not just leading, but are transforming and are really making a difference and change, that are prepared to take risks and also are seeing the windows of opportunities that here we can make a difference. And I would say that Kofi Annan was a very strong leader, really not being afraid, seeing the windows of opportunities, really being ready to transform. If you are slightly more junior, which most of us are, identify those people, follow those people to get inspiration from those people. Those are some of the competencies that are important if you're going to be a successful health diplomat. We had a conference in Stockholm now a year ago when we gathered people both from politics, senior leaders, emerging leaders, colleagues from institutions, including Gary and Lindsay. And we spoke about this. How can we basically advance the whole notion and concept around health diplomacy? And we published then also a paper with some of our conclusions in the BMG that you can also access. In Stockholm, as Paul has said, we have been running the first program with 28 fellows from 21 countries. Amal was one of them. This was a combined online, a hybrid program, 5 online workshops and a 4-day master program. And we will hear more about the programs now more in details from Oxford and from Toronto. So I won't go too much into what we have been doing here in Sweden. But I would like to finish because this is part of also of the consortium of universities for global health equity, to say that what we have started also is to connect academic institutions with an interest in global health diplomacy across the world. And right now we have 32 institutions across the world with an interest in this, and 9 institutions that have programs already up and running on health diplomacy today of different kinds. Some are more like what we did in Sweden, which is more of an executive program for mid-career colleagues. Some are part of master programs, and some are even also for undergraduates. I know that we got the Georgetown University up here to the left. They're running programs at the different levels for different students and for people with different interests. I stop there and see if we have any questions or comments on this. And I would prefer, we've got some questions here. In the chat, but I would appreciate if you can basically both if we can allow people to speak, so if we can unblock the microphones, and if you like to speak, you raise your hand and you pose the question yourself. I think we have Rahul. Would you like to come in with a question? Yes. Unmute, please.
Thank you, Anders. I was wondering if you or anyone else has done a cost-benefit analysis of adding another layer of bureaucrats, especially for low and middle-income countries who already have severe economic issues. Is just like a talk shop, or are there any real benefits?
I mean, if you mean that health diplomats is another category or cadre of bureaucrats, I mean, that's not the idea. It's rather that people that are working in different roles today, either in governments, and they could be what you call bureaucrats. But as I said, my view on what is a health diplomat is somebody that is passionate about health, that really would like to make a difference, but is specifically interested to navigate in a political process. Those are, for me, health diplomats. So they could be someone who's working in academia, they could be working in a private sector company, in a civil society organization, but they can also be bureaucrats working in governments. So I don't see, I mean, what we are basically trying to do more of now, that is to equip people with more knowledge how to navigate in the political landscape as the way of adding a layer of bureaucracy. It's rather to try to enable people to be more efficient navigating in political landscapes.
Thank you.
Thank you for the questions. I'm not sure how I can see now. Yeah, here I can see actually. Thank you. We have a colleague called Samuel Moro, please.
Yes, hello.
Yes, hello, we can hear you.
Yes, Dr. Anders, it's a privilege to meet you once again. I worked as an epidemiologist under your leadership back in Sierra Leone, I think in 2016 during the recovery phase of the Ebola, outbreak. Thank you for your leadership. I have been following sometimes your some of the great works that you are doing. I want to ask how maybe countries that are having struggling kind of health system, how global health maybe diplomacy can be used to maybe improve the health systems in these countries. How can it, is it a tool, a useful tool that can be effectively used to maybe contribute to the betterment of the health system in some of these countries, especially in lower middle income countries where the health systems are quite weak and they're struggling?
I would answer that with that there are two dimensions to this. One is then just nationally, and if you think about Sierra Leone, how to navigate in the national politics, understanding that. So in some way, those skills to be a diplomat is that you need to read the political landscape, or you need to understand how can you actually come to the kind of decision that you believe is important for people's health. So I think the kind of skills I spoke about here, they are relevant also how you navigate in national politics. To be able to understand, when I was there and during the Ebola outbreak, why was the Minister of Education sitting in one of the provinces saying that we should not immunize people against his own government? Why was that? to be able to read and understand the politics behind that, and then to have your network in terms of people to reach out to in terms of how can we basically make him to change his mind. I mean, that is in some way, you can call that diplomacy at the national level. But also for countries, low and middle income countries, regional and global politics is important. So even if you are a low income country and resource constrained, today, if I look at the African continent, the African Union is extremely important, and it has become much more of a strong political player. And then to have the knowledge also in countries, if I again take Sierra Leone or another African country, to have the knowledge about how do you navigate in that political landscape. It's those practical skills, knowing how to best to do that. And we'll hear a little bit from Amal, who is sort of beginning her career as a health diplomat. Again, what skills do you need, and why is this of interest to know some of this, even if you, as Amal, working in Somaliland, who is not the poorest, but still quite a resource-constrained country in Africa today. So that's a little bit my answer, that the skills are about navigating in political landscapes. Then we call this diplomacy. And sometimes I feel that by using that word, it sounds a bit too sophisticated and something only for diplomats. My view and my take on this, those are practical skills for everyone who has an interest in navigating the political landscape. Should we move on to Bonaventure Machuca? Please. If you can unmute.
Okay, thank you so much. Am I audible, please?
Yeah.
Okay, thank you so much. It's really an honor to listen from you, from the great insights and even the responses you're giving. So I was asking, one of the questions has been covered by my colleagues, especially on the global health perspective. So I was asking, when are these trainings for the global health diplomacy institutes and the network normally advertised? When are they formed? Is there a way you can help some of us? Sorry for not introducing myself. My name is Bonaventure Machuca. I'm a medical student from Kenya in the East Africa, and I'm really interested in global health, diplomacy, and also policy in the field of health. So I wanted to understand, is there a time when these calls are being made? Is there a procedure? What advisory can you give, especially to a young student like me? Thank you so much.
No, fantastic. Thank you for your interest. That's really encouraging to hear. I said very briefly and quickly that we have a network today of 32 institutions. There are 9 programs that are up and running today. We are working on a joint web page, so it should be easier for like yourself to navigate, to see whether there is opportunities for undergraduates or part of master programs, or if when you have been working slightly more years, more of an executive program for people that are more mid-career. So there are different opportunities, and right now there is not an easy way to find them, but in a couple of months, I hope that we will have a web page up and running where you can navigate and find those programs, and also information on when and how to apply. I think you will hear a little bit from Gary and Lindsay about their programs that are run from Toronto and from Oxford. But finally, I should say also that there are 2 institutions closer to you, the University of Global Health Equity in Rwanda and the Makerere University in Uganda, that are right now thinking about establishing an African-based program. So Amal and myself, we are going to go there in mid-November and to talk to them about how one can design an African-based program, because the interest is quite big. So we need more opportunities for people at different levels to be able to benefit from this. But there might be an African program, and there's also big interest from the African CDC to invest more in health diplomacy on the African continent. Let's go now to Axby Lu.
Hi. Hi, Dr. Anders. Thank you so much for the sharing. So I'm an MPH student at Johns Hopkins University. I was just, I think at the end of our presentation, you talked about some of the programs that you have with a couple of universities, and I was just wondering whether there are any ongoing discussions with Johns Hopkins, and otherwise, is there anyone or any contact that I can reach out to try to set something up? Yeah, thank
I
you.
mean, the closest that you have to Hopkins is Georgetown University in Washington, and Rebecca Katz. She's got a very ambitious and broad and diverse program already. So I would say that she's the best recommendation, sort of where you can get some advice. And it would be fantastic to see also Hopkins joining this. Should we take one more question before we move on? And then we take Netsane Mengistu.
I'm Netsanet from University of Gondar, Ethiopia. Can you hear me, please?
Yeah, now it's okay. It was a bit, yeah, now it's okay.
Okay, thank you. So I'm Netsanet from University of Gondar, and we actually are running a collaborative global health short-term course with University of Bangladesh. Sooner it will be starting in the middle of October. So in this case, we are also inviting other students to see if they want to take the training. And my question is, if you have any experience in the global health diplomacy, if two states are in conflict, and if the political landscape is not in a good status, and if there is a pandemic happening, is there any experience you have that these two states can work together through it can be like African Union, as you said, or is there any way that two states can sit together discuss about this stuff? Yeah, thank you.
I mean, in some way, I don't want to give a too pessimistic sort of answer, but looking across the world today, it's difficult. I mean, if I look back historically, it was much easier that states, even if governments, even if they were in conflict, they could accept help as some sort of common ground that could be accepted. I mean, we saw it now in Gaza that, I mean, there was a ceasefire so that one can go ahead with the polio vaccinations. So, I mean, in some way, health can be used as an entry point, a lever then to also to be able to negotiate and to get people and governments to come together. I mean, sometimes health is seen as a neutral ground in between countries, and there are examples of that. But I mean, unfortunately, if you look across the world today, it's quite a sad situation where people do not respect that any longer. No respect for life, no respect for healthcare workers. So it's difficult. But as part of the thinking around health diplomacy, it's not just that we need to understand and to learn politics if we are in health, but also that people that are in diplomacy, true diplomacy, in foreign ministry and are negotiating lives like for peace, that they can also see how they can use health as an entry point. And I think we will hear a little bit about that from Ambassador Jimmy Kolke later on, how health can be a means also for diplomacy and foreign relations. But it's, I mean, we're living in a tough world right now. So in some way, I wouldn't say that I don't like your question, but it's it's points to the reality of today, which is very difficult. Let's save the rest of the questions, and we will get back to more opportunities to questions. But let's move on now to the next session, where we will hear a little bit more in detail about two programs, both about the programs, but also their experience of engaging people that have an interest in global health diplomacy. And we will start with Lindsay Baines from the UK and the Oxford University. Lindsay, the floor is yours.
Thank you. So I think you can see the slides on the screen now. And it's going to do.
If you can do a full screen, that was my problem.
All right.
What I learned is that you should do full screen before you start sharing. So if you stop sharing, full screen and then you share.
Right. Okay.
Oh, it's okay. We can very well see it, so that's no problem.
Yeah, I can change the slide. So I'm not used to Zoom. I do apologize. Okay, so good evening, good afternoon, good morning, everybody, wherever you are. I'm going to, as Anders was saying, I'm going to share a few of our experiences of both validating new global health diplomacy content and also trying to integrate global health diplomacy content into existing courses, which in some ways can be easier, although it can be more difficult. And hopefully some of what I say will resonate with you, and hopefully you'll have some ideas and you'll be able to share your own experiences as well. So in terms of our approach to integrating global health diplomacy into the university space, the university space is very competitive at the moment, and you're competing with lots of other global courses. So we've taken a sort of two-prong approach, really. The first is trying to integrate global health content into existing curriculums. So you only need to look around the curriculums of your own university to see that there are lots of courses prefixed with the word global. So you pick the sort of most likely candidates that represent the core skills of global health diplomacy. So if you can find courses in sort of politics or global health, tropical medicine, etc., then they are usually likely candidates. Although it's still not quite straightforward because, of course, faculty sometimes can be resistant to change. They can be defensive of their own offerings. So it's not only about trying to mapping your content to their content and helping it to complement or to build upon what they're already offering. It's also, you've got to factor in that, faculty might need some professional development. You might need to lay on conferences and workshops and kind of slowly sort of win them over. Also, the leadership of the university, where we've been very fortunate, needs to really recognise the value of health diplomacy and also to reward faculty and to show that they feel that it's important, and to reward faculty with awards and promotion, etc., and recognition. Also, the Students' Union can also be very helpful. Once the Students' Union realise that this is that global health diplomacy contains a lot of the skill sets that employers require of graduates and helps fill that kind of university employer kind of gap, then student unions can be very powerful allies as well. In terms of generating new courses, it's worth remembering that it's not just about the funding, which is a huge issue, but also about the marketing and meeting quality assurance as well. Also, that there are so many courses at the moment in most institutions prefixed with global, that one of the most likely questions you're going to be asked by any credentializing panel is, why do we need another global health diplomacy program, and how will it help us? So you need to really be sort of ready with your answers. So moving on from that, it might just be worth just taking a few minutes just to explain the geopolitical landscape here in the United Kingdom. Recently, our student visa laws changed, which made it impossible for our graduate students or our level 7 students studying for master's degrees to bring their dependents with them. In some ways, it made it kind of easier for us on some level, because many of them would come on quite a low budget, particularly from low and middle income countries. And we would have a lot of, small people joining our lectures. And sometimes they were more well-behaved than the actual students themselves. But that has been quite a challenge for us. And also, as someone was mentioning earlier, in terms of actually getting visas and being able to cross borders. One of the ways we've kind of adapted to that really is to start to recruit and start to develop more sort of hybrid PhD programs, because the PhD study, the doctorate programs are not bound by the new visa rules. Also, trying to credentialize new courses can be tricky because, as I say, there are already many courses in the space with the prefix of global. But what I found is that, again, coming back to this, there's been a lot of talk here around the disconnect between university offerings, the skills that graduates have at the end, and what employers require. And if you can hit those kind of keywords with the credentializing panel around digitalization, politics, socioeconomics, English and math and developing new policy, and negotiation is a huge one as well, then things tend to sort of flow a lot more quickly. So the role of global health diplomacy in achieving the SDGs, particularly SDG 3, does capture the imagination of credentializing panels, but particularly also of the students, particularly SDG 3, ensuring healthy lives and practice and promote well-being for all ages. It captures the students' imagination, and it also leads to simulated exercises. Just on if you have a mixed group of students with a good mix of low and middle income countries and high income countries, and you just sort of focus, for example, on universal health coverage. How is it going to be funded? What policies need to be changed? What new policies need to be introduced in their particular countries? Really, that could take up a whole course, to be quite frank. I mean, that would keep everybody busy for some time. Because remember, even in high income countries like the UK, where we do have socialized medicine and we do have healthcare, which is free at the point of entry, it is rationed and it is becoming more and more strained, and there are very long waiting lists as well. So as I was saying, we've really taken a sort of incremental approach, slowly sort of feeding and infusing global health content into existing courses, and trying to generate new courses. We started off with a short graduate course, which was 1 week. It was campus-based. As we heard earlier, most of these courses are campus-based. It attracted up to 40 students from 28 different countries. We were really surprised, even ourselves, about the broad cross-disciplinary mix of students that we attracted. You know, we had students from all over the world working in all different walks of life, not just from people who are working in diplomacy. So we had a few people attending who are actually in charge of funding and providing funding and evaluating grants for funding. And they actually told us that the grants have become so complicated, they felt they needed to come along the course to understand what they were really seeing. We have people from insurance, people from government, from non-government organizations as well. Also, we also started to integrate global health diplomacy into leadership programs. So in less likely fields such as business and MBAs, particularly around negotiating, that was very, very popular. We really started working on the MSc Global Health Diplomacy and Security before the visas rules were changed. And so we're kind of sort of put that on hold, and we're concentrating on the next step really, which is around PhD. So what are we looking for when we're recruiting? Well, of course, we're looking for people who are enthusiastic, but we're looking for a strong professional experience. It doesn't have to be in diplomacy, because most of our students are not working in diplomacy. They are aspiring to work in diplomacy, like some of our callers have been this evening. So we're looking for portable skills. So these skills might be in a different context, but are they portable into, for example, diplomacy? So we're looking for skills such as people who've been working in public health, who have public health knowledge, scientists. We have quite a few scientists are well represented on our programs, but scientists may not have actually been involved in negotiation and diplomacy. We have a lot of people with economic backgrounds as well. And we're looking particularly for people who have worked in cross-disciplinary settings with people from cross-cultural stakeholders, people from lots of different backgrounds, and who can have a starting point to a project and demonstrate an end point to a project. So all of those skills can be portable. They can be out of context, but as long as they have some sort of potential, you'd make a good candidate for the course. So no surprises here, really. We run the course over 2 weeks, and rather like the findings that were presented to us earlier, we run it as a campus-based program. We find the students prefer that because they're all busy people, so they're able to take some time out of their busy working life and also come to the UK and then visit relatives maybe in Europe as well. We aim to take in about 40 students. As I say, they're mainly early to mid-professional, although we do have some more senior members of staff as well. Last take, it was 28 different countries are represented. Also, we have a slight female bias, slight male bias. I mean, we have some gender bias here. We have 48% female, although they're very good at making their point. And we have a GMAT medium 680, although there's not quite so much emphasis upon that because people may have been GMAT a long time ago. But acquired prior learning, whereby students have worked in these kind of cross-cultural settings, and they have some knowledge which was portable into the global health space. So we have core competencies in the program, and negotiating has to be right up the top there, because one of the things we've noticed that however senior students are that come on the course, however many years experience they have, we've been really surprised at how many actually have experience of being exposed to actual face-to-face negotiations. That is by far the most popular part of the course. And so we've listening to student feedback, we have really grown that in our program, and we've developed that now. That spans over 2 days. So that takes up 2 of the 5 days. It's just simulating exercises around negotiation and actually face-to-face negotiation and what the stages are. Also establishing new governance. Many students can tell you what's lacking in their governance, and some may just have very old policy which needs to be updated. But the sheer effort that goes into introducing new policy and the political game playing that's around that is really quite shocking. The creating of alliances in support of health outcomes. Well, we do integrate into our teaching sort of techniques that will ensure that all the different countries don't cluster together, that we have a good mix in each group, and that we start dialogue. And rather like Anders was saying about cooking, and that kind of brings people together and breaks down barriers, we tend to do sort of social events and, a sort of fancy dress where people have to dress formally. And that sort of generates quite a lot of excitement as people are focusing on what they're going to wear. So it's rather sort of like that. Also, building and managing donors and stakeholders, again, is something that's very, very popular on the course. And we usually invite a donor or a significant stakeholder to come to the course. And we had someone from the Wellcome Trust, we've had people from Pfizer, had people from Doctors Without Borders, and also the King's Fund as well, come to talk to the students. And they will say quite openly that they prefer to put their money where it has a track record. And so then the next sort of question from students is, if our organisation does not have a track record of funding from your organisation, how do we go about doing that? Well, of course, the way to do that is to partner with other organisations that do have a history of funding with particular organisations. Responding to health crises and health preparedness is hugely popular. And we usually invite people from our emergency response teams to talk to students. And improving relationships through countries, that is really interesting. That usually leads to some really interesting discussions among students, which usually go on into the social events as well. So I think Anders touched on this earlier, that in terms of challenges delivering global health diplomacy, anyone who's taught either formally or informally, even if you run just workshops within your own facilities for staff, you know that when you have a whole cross-disciplinary group of students, all coming from different disciplines, they're all been trained in different protocols, they've all been trained in different definitions of items, they all have different ways of working. And one of the challenges is running global health diplomacy programs is bringing everybody to the same point. So you quickly need to get people to the same point. And one way to do that is through negotiation and factoring in the SDGs. So negotiation, the SDGs, and forming alliances. We introduce that right from the beginning, and that helps to sort of break down the interprofessional barriers. So all the doctors are not sitting in one corner, all the scientists are sitting in another corner. Also, lack of diplomacy experience is something that we're looking to generate. We find that we do form a writing group, which is led by Professor Jindal. And for most groups, we do publish a few publications afterwards in journals, in high impact journals. We've published on issues around diaspora diplomacy, which is very popular, onco policy. And also we've published some papers around the impact of popularism on global health negotiations as well. The students really like that. And they tend to form their own WhatsApp groups, and then we can track and help them as they go through their careers. And then really finally, as I was saying, the biggest challenge is the unifying students and bringing them together, and also getting them to break down barriers between professions and between countries as well. But again, you have to build that into the curriculum and build that into the course. So there is a little bit of future reading here. The final paper, number 4, was something actually that came about as a result of the meeting in Stockholm that Anders was mentioning earlier. That's a good read. Also, as part of our Excel course, we published on onco policy and global health diplomacy, cancer and oncology being right up there at the moment as a priority. And there's a few others which I noticed which have been published very recently, which I thought you might make good further reading. Okay, thank you. And of course, if you want to get in touch with me and share your experiences after the webinar, I'm most happy to hear from you.
Thank you so much, Lindsay, and sharing both your experience, but also your take in terms of how you can contribute to improving the skills and competences and respond to the interest from many people across the world. Fantastic. I mean, you've been doing this for quite some years, so you are a front runner here. Great. We will also listen then to Gary and hear a little bit from you on your experience then from Canada and Toronto, and then we will open up for comments and questions on this, because this is also a program that has been in place for quite some time, so you already have some experience. And here we have a new definition of global health diplomacy. Wonderful. Gary, over to you. You're muted.
Great, thank you. So I just showed the website and I shared a link in the chat, so I don't have to come back to that. And please, you can find most of the information on there. Now I'll share some slides. And again, thanks for having me. I'm here in my hat of helping with this course that really has been something that I've felt that many of the public health or policy types who work in government, when I work for federal government of Canada in Ottawa and have been behind the Canada sign in various meetings, was really something that was missing. And hence having the affiliation with the School of Public Health in Toronto helped me to propose and luckily partner and work closely with my colleague Erica Di Ruggiero to introduce this course that we've done. And from the very beginning, I need to say that we call it an executive course because we only look at those who are either working at the moment or are at the cusp of working at areas that really could be defined as health diplomacy. We recognize the huge need, and Lindsay mentioned at master's, PhD, etc., and program in Georgetown, we know have a lot of undergraduate exposure, but we don't have that capacity, so we're looking at executive education, so to say. We were about to go with our first call for applications in 2020, but you know what happened in 2020, and however, by September of same year, it was clear that global health diplomacy was unfolding on TV screens of majority of people in the world. Hence, our dean said, go with an online version of it, and we've done that. And I'm quite happy that we did that, and there was no shortage. What we've learned in the last 4 years, and if we compare with learning done at the time when we were taking courses a few years ago before pandemic, is that there is no more really a reason to only concentrate on in-person learning. However, the virtual version of it really lacked the fullness of putting together the negotiation and simulation exercises that we had in mind. Hence, we've actually landed at a mixed model, which so far has worked quite nicely. As I would say 99.9% of our learners are working and have full-time jobs, easily, sort of slowly, step by step, immersing them in module 1, and that's the structure in front of you, into the concepts of global health diplomacy, characteristics, call it competencies, and where we are now, both in terms of health and foreign policy, and also bringing the Canadian perspective. And I don't really shy away from reiterating that the course focused on the Canadian perspective, simply because that allows learners to have a position from a country of a certain size, role, challenge, situation, and geopolitical environment it is in, even if they are not from Canada. And we have about 30–40% of our learners coming from globally, from various parts of the world. And when they get a bit scared that they need to know everything about Canada and also about the country they come from, I do tell them that take this as an opportunity and as a way to learn about your own country through the lens of this, as well as about another one, because only through knowing what you're negotiating with whom and what their position is will make you a good diplomat. And that kind of helps them to ease into that. I need to tell you again, this is not a global health course. I do sound as a broken record sometimes. If people want to take a global health course, we tell them there are many, including at the School of Public Health and in other parts of Canada, internationally, and in broad range of universities. But this is not a global health class course. You're not going to learn about global health in this course. You're going to learn about health diplomacy. And also, once they've eased into immersion of some reading, and reading is a challenge these days, so podcasts, other things. And in my day job, I actually help produce a podcast. So we have some episodes from there and then some others. And we bring some interviews, videos that we've collected over the few years. And we allow that for learners to immerse into it. And then they are divided into cases of real on-the-ground cases that take place during the course. And there's no shortage of those. It's the best time to teach global health diplomacy. And they can find information on that coming at them day in and day out. And that's how, in reality, the diplomacy is anyway. And be aware of both real information and misinformation. Then we have the module 2. For some reason, it says 3. Ignore that. Where we have the face-to-face 2.5, 3-day program. And then we have simulation exercises in them as well, where they apply. And then they also present the position into negotiation position they go into. And then they wear hats of both their countries or collection of regional groups or regional sub-blocks, or representing a group of countries where they may have common positions, and we give people time to do that. So obviously it's very hard to explain everything in terms of what's happening in the class, but just to say that we try different ways to expose the actual knowledge as acquisition, and not just to say go read an article, but make it really broad-ranged according to what people actually, how people consume that knowledge these days. And most importantly, then the practical part, which is extremely important, and there's no executive course without a practical part. Who are our learners? So you'll have the public health types who have been thrown into some of these jobs. They know everything about public health. They don't know anything about, I don't know, trade or foreign affairs or geopolitics. That's fine. and they will learn at their jobs. There was a question, I think, earlier, are we creating another layer of bureaucracy? I probably would say no. What we hope to do with those who take our course is to make them skilled with things that add to their basic experience and expertise, and not to invent some new people. And also, of course, we have a big chunk of people who work with Canadian federal or provincial health and other policy advisors. We have people who work on trade, climate, other sectors. Obviously, every resolution or negotiation that they will encounter will never be purely about health. It will be about other social, environmental, trade, geopolitical, you name it, issue. And health is, of course, the core, but and the multi-sectorial nature of every single negotiation cannot be ignored. And we have some private sector executives who work with governments. We have health attachés who are diplomats, perfectly trained in foreign affairs and service, but then they are stationed in global health diplomacy hubs like Geneva or New York. And now they have to go through excruciating meetings at WHO and other buildings in Geneva, and be thrown into a barrage of acronyms and things like that. So they love to hear more about that. And then we have a huge number of people who work for international and intergovernmental organizations who do diplomacy at a different level and different way. And we have core faculty, a couple of us, and plus we have usually a senior advisor we engage from outside, but we do not ever want to come across that me or Erica or anybody else who is involved know everything about everything. Obviously, we engage a whole range of senior diplomats, current mover shakers in global health diplomacy. We also have former negotiators who are a bit more free to say things. We also have a very well-established global expert network that we call an expert, and we call them for half an hour online on the screen, and they tell us everything about what they do and get to be asked questions. And then we have a range of advisors that are available to learners to answer questions as they work on their cases. So again, no one person knows everything about global health diplomacy because every experience fora, where you come from, what topic is, has a unique perspective that you need to be exposed to that in order to come out of this and say, now I know what's happening and I can look for the right things at the right time. And then we also have public health professionals who work in public health on the ground, and they come and tell us what the global negotiation actually means for the municipality they work in, because no need for us to negotiate health that it just helps only or stays in Geneva, New York, etc. So that also has to make sense to the public health professional one way or the other. I'm not going to go into a lot of numbers. I can tell you in the last 4 years, and we just opened our application, we are working closely with the Office of International Affairs for Government of Canada, and we established a LinkedIn alumni page. But just to tell you that the numbers have always been going up. There is no shortage. I think Anders mentioned earlier that there's no shortage of interest, but there's also need to be recognition that this has to be on top of, at least for us, on top of another already existing skill set that it enhances and makes it practical for those who are coming out of this great experience. At least that's what they tell us. If you go to our page, you'll see a lot of videos and testimonials. I am not going to go into advertisement here. I want to put things also into perspective to say that in addition to actual course, at least at the level in Canada, we tried, or at least to use this as also, and there was a paper developed in terms of debate overall on the needs for global health diplomacy, politics around it, and need for coherent strategies at different levels, in this case for Canada, and also having that openly discussed, so the learners also understand that this is not a purely also only academic exercise, and universities are well placed to train, but universities also sometimes lack expertise in real life negotiation. Hence, it's a perfect thing to merge things together. No one or the other only expertise would actually help in putting something like this together. And as I said, I put 2 episodes of our podcast, Global Health Matters, where we focused on geopolitics. Why I put it here, that both of them had one of the highest numbers of downloads. So there's clearly interest in global health and those involved in global health to demystify this also, that the words like geopolitics, etc., may sound intimidating. And I think in this case, 2 guests here have done a perfect job with that. And we do need to hear from a lot of people to really form our knowledge and form our position. I will stop here. And
thank you, Gary.
Yeah.
Thank you so much. So, I mean, you have got basically now 2 examples of programs, and I've seen in the chat that many of you ask, when can I apply? How can I apply? Which is, of course, fantastic. And I said also a couple of words about the program we run from Sweden. But let me say before, I think we can have a couple of questions. But before that, just to say that, as I said, there are 9 universities in the world today offering these kind of programs. So you've got Oxford in the UK, Toronto, you've got Georgetown University in the US, Graduate Institute in Geneva, you've got also Islamabad in Pakistan, you got Bangkok in Thailand, you got Beijing, China, and you got Tokyo in Japan. In the making is a program in Africa, a regional program for Asia, either from Singapore, Australia, or both. So there are new opportunities, but I just want to, before both open up for a couple of questions and then taking us to the last part of our seminar, say that this is quite some specific skills that we are trying to focus on. How to navigate in the political landscape. But then, of course, you might have an interest, as Gary said, in global health, in tuberculosis, in child and maternal health, understanding the international system and the organizations. There are many other opportunities. So I think it's important, depending on where you are in your career, if you're a student, if you're a practitioner, to think a little bit in terms of what is it that you need in terms of your skills. Is it basic knowledge about global health? This is part of the consortium of global health universities. And I think in that network, I think there are 200 plus universities. So there are huge opportunities if you like to learn about global health broadly here. We would like here to add to what is possible, also to have an opportunity to learn about the interfacing between politics and health, which we call diplomacy. Let's have a couple of questions. I saw a hand somewhere, but I think that one, someone took that down, because we should have a 10-minute break as well. But do we have any specific questions on this? Because after the break, we will have the great pleasure then to listen to and to discuss and put questions then to Ambassador Jimmy Colker and to Amal Alil, who are both practitioners, who have and is doing this kind of work in practice. They are not academics, they are practitioners. So we will hear from them how they see this practice and possibly also giving you some inspiration why you should go down this line in terms of your career. We have one question from Alberto Martinez, Police. Please introduce yourself.
Hello. Yes, I am Dr. Alberto Martinez Bullis, normally in the humanitarian field. One question so from Dana School. Is Dr. Orbinski involved in the program, number one? And number two, in general, for the whole consortium? I wrote a question before, is there in the chat, about global health diplomacy for critical crisis situations for humanitarian action organizations, for example, critical incident management, but that's another thing. But the connection on non-governmental actors on how to navigate the formal system of engagement, right? The different forum, the Geneva, I don't know, the World Health Assembly in this case, or Pan American Health Organization, how to engage with them when you are not a politician per se from a country or a party, but you are, for example, from an NGO world, which turns it double difficult, right? So that's my two questions. Thank you.
Thank you. Lindsay or Gary?
For the first one, just to say that Dr. Orbinski is with York University in Ontario, and that's about 6-7 stops north of University of Toronto on subway. And the quick answer is no, but they have a global health program, and check out, I think they have a whole range of programs there as well. So it's York University. It is in Ontario, but it's not the same university.
Your other question about sort of specifically focus on humanitarian settings or crisis. I mean, there is also opportunities if you have a specific interest in what we call humanitarian diplomacy, which is not on health, but more humanitarian situations. I mean, there are other programs that you can search for that. But at least in our program that we run in Sweden, I mean, we also had that aspect in terms of how do you basically negotiate also humanitarian settings. And we had a couple of our faculty with that kind of background, but there are also specific programs, I would say, if you have a specific interest in conflicts and humanitarian settings. Mustafa, and then we should take a break. Mustafa disappeared. Okay, so let's take a 10 minutes break and we will be back here then. I don't know what time you have, but for me it will be 5 past or 20 minutes to 9. And I suppose in different parts of the world there's a different time, but 5 past the half hour basically. So in 10 minutes, 35, at 35 something.
Anders, I apologize that I was not available at
No,
1
no,
o'clock
that
exactly.
was fine. That was fine. No problem whatsoever.
I've appreciated hearing the other presenters, though. I'm sorry I missed Paul's summary of your survey.
Yeah, he actually, I've never done it, but he was actually, because he couldn't be with us now live, so he spoke to the slides. And obviously you can do a PowerPoint where you actually record your presentation with the sound.
Uh-huh.
You just click on the presentation and then it's like he's speaking like he's been with you. Worked
Oh,
very well.
yeah.
I've never done that.
It's a good trick.
Yeah. So I can
You
share that.
you asked us to share tricks. I did. That wasn't one of them that I'm going to be able to share, but I'm glad you can.
But I think we have, I don't know how much people are listening now, but it doesn't matter. But I think we have a mixed audience of quite a few students. But as this is part of this consortium of global health universities, we've been speaking quite a lot about, I mean, what are training needs, what are training opportunities, approaches, etc. But I think quite a few people are possibly not sort of trainers or teachers or more on the academic side, but more interesting in the reality. So most people are interested in what training opportunities there are there for them, but now also to listen to you and Amal about what's the work in practice.
Well, I'm honored. I'm honored to be able to share my experiences. I hope that they're useful.
Yeah, thank you. Thank you. Are you back home in the US?
Yes. I was in New York last week, but not as part of the U.S. delegation, just on the margins of the UN General Assembly. So many side meetings and what they call summits going on, but I got a lot out of it. I learned a lot.
I didn't go this year. I was in the other direction. I was in Bangkok doing something else. But on the Swedish side, I was very happy to see on the social media the new Swedish Global Health Ambassador. You must connect to her. She was the former Director General for the Swedish Public Health Agency, Karin. What I saw from New York, really, really good.
I look forward to that, but the meeting that Secretary Blinken chaired, in which I think she attended, our side was very pleased with. So I hope that, and we're trying very hard to get someone to attend the meeting in Berlin that she'll chair.
Yeah, I don't know whether the invitation is out for that. Yes, I'm seeing her tomorrow, but yeah, no, I saw her at the same table as your secretary. That was very good. Très bien. And Amal, you are in Hargeisa.
Exactly. Hi, Jimmy. So nice to see you again.
Yes. Good to see you.
Amal is joining us now also in Kigali in a couple of months' time, or less than 2 months, for a sort of a program design planning workshop to establish an African program, collaboration between Uganda and Rwanda, Makerere and the University of Global Health Equity.
Fantastic.
We'll see how that goes. And Amal has been very helpful also with the contact with African CDC.
Excellent.
And Gary, I think you will have quite a few people now, even more people applying for your program.
Yes, both of the programs sounded well worth attending.
What is also, what I appreciate, we'll see when we can get this webpage up and running so that people can have access and easy to navigate to see what is there. But also the podcasts that Gary has done, really sort of interesting talks with people, and to be able to spread those more widely as well, I think is a good idea.
Well, the two he had on the screen, Yode and Ricardo Leite, are both inspirational.
Yeah, very much. I think we could start again. Sarah, I don't know whether you can hear me. Are people connected so people can hear us?
Yes, we still have around 61 attendees, so it's fine to start up again.
Okay, thank you. Thank you so much. So a big thank you again to Lindsay and Gary for sharing information about and experiences from your programs. As I said, I'm very happy to have two practitioners with us. One, if I may say so, a very senior one who's been doing this work for quite some time and have a lot of experience navigating in different political landscapes than Ambassador Jimmy Colker. Jimmy has been the US ambassador, not on health, but the general ambassador, both to Uganda and to Burkina Faso. But Jimmy also has been the head of the international department at the Ministry of the Department for Human and Health Service, HSS, in the US, basically leading the work from the Minister of Health in the US. Plus have had a number of different hats and is today an advisor to the State Department in the US. But then we also have Amal Ali with us. Amal is slightly younger, earlier in your career, and was part of our fellowship program in Stockholm, but was also part of the Kofi Annan's Fellows program, and is one of, I would say, the emerging leaders when it comes to becoming a global health diplomat. So what we will do now is to listen to different perspectives in terms of your take on how do you do this? What are your sort of thinking for the future, Amal? And Jimmy, your thinking possibly of today, but even more looking back, your experiences, what you have experienced that you can share with people that have an interest in this for the future. And I think we will start with you, Jimmy, and then we'll go to Amal. So Jimmy, please.
Well, thanks very much. Can you hear me?
Yes, very well.
Yes, good. It's really thank you, Anders, for inviting me, and it's a pleasure to see Amal again and be on the panel with you, and to take advantage of the platform that CUGH and Keith Martin and Sarah offer. We did have a program which we co-sponsored with them for this new bureau at State Department called Global Health Diplomacy and Security, which had nearly 400 participants. And I think there's some overlap with this open week that CUGH is sponsoring, but I'm just delighted that there is so much interest in global health diplomacy, and especially the intersection of where policymakers and health professionals, academics can discuss what we do and enrich each other's chances for success. And so while I am working part-time back at the State Department, I'm kind of in remission as a diplomat, but I am working especially on helping to build capacity within the US Foreign Service, within the US embassies abroad, to deal with global health, to make it an important bilateral issue in every country, not just where we have aid programs or where there might be an outbreak, and also to look at how we better engage ambassadors and deputy chiefs of mission, the front offices of embassies, to see health as an area of engagement, not just when there's a crisis, but where national security can depend on having the right contacts, understanding what comparative advantages are, both of American institutions and of our partners in countries where they're working, and worldwide in multilateral institutions. So there's a lot to be done and a lot of opportunities we've missed historically. But I should emphasize that I'm not here representing the Department of State. I am going to talk a little bit about my personal experiences. And probably the most formative one was that I was ambassador to Uganda when the President's Emergency Plan for AIDS Relief, the PEPFAR program, started in 2003. And what I quickly realized was that the PEPFAR goal was national scale up. We were trying to reach everyone in Uganda and in the 14 focus countries at the time who needed treatment and didn't have access to it. And we had already had a number of AIDS programs and very successful health partnership programs, but all of them were in the area of proofs of concept or pilot programs or centers of excellence. And these were very professionally run by USAID, by CDC, mostly by medical professionals. But national scale up is something different. And so we're now in an area of national ownership, of universal health coverage, the sense that we can have one laboratory or one site, often at a tertiary hospital or in the capital city, where we can have a successful program and then leave it to someone else to scale it up is no longer the way global health should be working or health cooperation should be working. And that it turns out that the biomedical concepts needed skills which diplomats have in order to make this national scale-up program a success and to build on the partnership between Uganda and other countries and the United States to make these programs work. Because you needed diplomatic skills, you needed economic investments, you needed to figure out how to work in conflict zones and who different partners might be. There were ethical questions, there were sociological issues that needed to be addressed by the foreign partners. We needed a kind of cultural understanding and an ability to work with different kinds of partners in different parts of the country, sensitivity to gender, sensitivity to youth, that simply doing a pilot program didn't always have to answer. And so I recognize that diplomats actually could play a key role in the success of public health interventions. And PEPFAR turned out to be that program that was able to succeed. We were able to scale up. We were able in Uganda to meet those goals of reaching tens of thousands of people who needed help in those first couple of years. And what do diplomats need that's different from scientists and from others working on research projects or on proofs of concept? One is that we need just-in-time information. We have to figure out whether once we're starting a program, we can't step back to see if it's working and take time to do lots of readjustments. We have to pick some partners, go with it, and try to complete the program to meet deadlines and to work with the political forces and the issues that we face with the resources that we have. We can't stop and start over once the program is underway. And you need that just-in-time information and a sense of risk management. How are we going to deal with the questions that do come up? Scientific articles, which many of you write, start with assumptions. Oh, we didn't do any of these clinical trials with women of reproductive age or with adolescents. But boy, if you're trying to start a HIV treatment program, you're sure going to want to work with women of reproductive age and with adolescents. So the sense that we can pick our audience or make some assumptions isn't going to be very helpful to the policymaker or the diplomat. And then they always end with more research needs to be done, and that's often useful. But clearly, when we began the AIDS treatment program, we didn't have 10-year longitudinal studies of what might be potential side effects that could affect those people who were on getting chronic care, who would be having to take the drugs for the rest of their lives. We had to weigh the risks of would their own health, certainly in the first instance, but also the reputational risk of the United States. What would that be if it turned out there were serious side effects of which we were unaware or which we couldn't anticipate, or how could we weigh the risk that those side effects could actually destroy the reputation of the program or make it ineffective point of view of public health? So all of those public policy issues, which a researcher doesn't really have to take as much responsibility for, or could say more research needs to be done, are very much on the mind of a policymaker who's responsible for funding or implementing that policy. Finally, in terms of bilateral relations, multilateral relations, written agreements are very important. And there are many governments, in fact, where scientists are reluctant to cooperate with foreigners if there's not some kind of scripture that they can cite to say that I have political authority to share information on these topics with those foreigners. And I think while scientists are predisposed and should be to saying knowledge knows no borders, I want my information to be used by others, in a political context, that isn't as easy as it sounds. And the question of who has intellectual property rights, who has commercial development rights, who has the ability to take a product and use it in a specific circumstance can be quite complex. And often if there are science and technology agreements, and certainly the kind of memorandum of understanding or the contract by which this cooperation takes place in a low and middle income country with a partner from a developed country is very important to setting the ground rules, both to protect the rights of the people in the country where the program's taking place, but also to be sure that the donor or the people providing technical assistance understand the terms under which they're providing that assistance. So those are kind of at a bilateral level terms that are important to me as a diplomat, which sometimes the researcher or the scientist or the medical expert isn't fully aware or doesn't really understand. It's not a culture in which you're working. On a multilateral level, and I did in my job at our Ministry of Health, Department of Health and Human Services, represent the US on the governing structures of the World Health Organization for several years. And it was certainly the US responsibility that we had to be the best prepared delegation. We had to actually know what was at stake in almost every resolution and be prepared to answer questions about what would this language or that language in that resolution or in the report that we were discussing, what did that actually mean and what would be the implications of approving it or adopting it. I have to say that from a expert's point of view, from a scientist's point of view, from an academic's point of view, you may have a much different role. And you're probably interested in managing one issue. One that has recently been on the agenda, for instance, is folate fortification for spina bifida. There are a number of neurologists who have pushed these issues. There's a long history of research. It's been a good example of cooperation, for instance, between the United States and China in looking at those issues. And suddenly it was something that they wanted the WHO to say that every country should have a plan to look at folate fortification as a way of preventing spina bifida, neurological disorder that's very disabling, but preventable. And so the advocates for that point of view, who are mostly scientists led by neurologists, actually, first looked for countries to sponsor their resolution. I think they chose, if I remember correctly, Colombia and Ethiopia as advocates. Very good ones. They're geographically diverse. They have good track records themselves in many public health interventions. But then it's a multi-year process. You want to have side meetings. You want to have intellectual conferences. You want to have an article, maybe in the Lancet or another international journal, about the implications of both the disease and the solutions that you're proposing, and talk actively with member states in capitals, in Geneva, at international meetings. And it's a 2 or 3 year process to get that issue ripe for a resolution, which then did pass, and WHO now has mandated that countries have national plans for issues like that. But if you're looking as an academic to say, well, I really care about this issue, I have an answer, we need political will to implement this. Political will is not just a light switch you turn on and off by having one meeting with one prime minister. Political will is something you actually have to build up through a process of looking at the institutions and the people who are involved, winning over their confidence and showing that you do have a solution that's in their interest. You have to put your solution onto their agenda. And that's a process that takes both data and evidence and time and strategy. So I'm happy to talk about my experiences.
Thank you so much, Jimmy, for sharing long experience and interesting and important experiences. 2 questions. Can there be a conflict in between then expert advice and the political reality and the political priority, public health priorities, political priorities, conflicting? How do you deal with that?
I think conflict might be the wrong word. Not everything that scientists or medical people do is a political priority or is ripe for a policy action. And sometimes people are very passionate about what they do and have partners and would like people to scale up their programs, but it turns out that either the timing isn't right or the other preconditions aren't available, or there are just a whole lot of other priorities. And so this question of how do you define what you need to do and say, here are the number of people who are affected, here are the economic consequences of inaction, here are the medical consequences of inaction, and this is why you need to put this on your agenda. That's building the political will. But not every condition or every innovation rises to that level. And I think somebody asked earlier about, well, what if the countries don't even agree? What if these are countries that have a level of hostility? And the bar you have to climb or you have to get over to say, this really is in our interest, we have to do something about this problem, rises dramatically when the political situation is tougher. The more political obstacles there are to reaching a solution or to finding a partner, the harder it's going to be to make that argument on a biomedical or an economic or a public interest level. So it's not that these are in conflict necessarily, but you do have to make the case.
But you believe that evidence will always win in some way?
No, I think we have many examples of where people make decisions which are not based on evidence, and we often suffer for it. Sometimes it has more consequences than others, but no, evidence doesn't always win.
Second, slightly different question before we move on to Amal. You spoke also about the diplomatic skills and different kinds of skills, but specifically the diplomatic skills. What are those, and which has been the most important skills that you have used and applied and during your life?
Yeah, I think one of them is curiosity and just willingness to listen, trying to learn quickly about an issue which is important, but which you don't have expert background in. So who are the experts to whom you listen? What questions do you ask? How do you get a quick grasp of what's actually going on? And then in the case of a national diplomat like an American, what comparative advantage do our institutions have? I mean, in many cases, U.S. Centers for Disease Control and Prevention do have the world's best experts on a disease. They've done great research on something. They're able to address these problems when they occur domestically in the United States. So we have already on the payroll some really important people who could address an outbreak or a question or a condition or a structure that is occurring overseas in the country where I might be located. Meningitis outbreak in Burkina Faso was a great example of that. And so you try to get those best experts there, but you need that knowledge of what your comparative advantages are, who they connect with in the country where you're serving, and then to be culturally sensitive in how you present that answer. I mean, you talked a minute ago about Rwanda, which is a very capable, but also a very proud country where Marburg has just broken out. And we think we can help in the addressing and containing the Marburg outbreak, but we have to do it on Rwanda's terms. It's not that the US should come in and say, we know how to fight this and please step aside, elbow aside. We're going to fight the Marburg outbreak in Rwanda. That wouldn't be effective because the Rwandans have their own capacity and they're going to do it their way. And we need to be able to be sure we're adding value to what they're doing, not trying to do it differently or doing things our way when clearly this is a partnership in their country with their people as the people at risk.
Thank you. Great. I think in the case of Rwanda, it's not about it wouldn't be efficient, effective. It wouldn't be acceptable at all. Would never happen. But no, good practical advice. Should we move to Amal then? I mean, what is your perspective about health diplomacy? What does it mean for you?
Thank you so much. Good evening, good morning, good afternoon, wherever you are. I think I just want to start off by thanking the organizers and particularly Anders Nordström for giving me this platform to share some of my experience as an emerging global health leader navigating in the space of health diplomacy. I'm also very honored to be wrapping up today's session with none other than Ambassador Jimmy Colker, who I've had the pleasure and opportunity to meet and interact with during my participation in Stockholm in the executive course, Diplomacy and Politics for Health. I'm going to take a few moments and try to explain a little bit the context that I work in. And I'm also going to probably shuttle back and forth from Sweden and then also to the Horn of Africa where I am right now. So please bear with me. So I grew up in Gothenburg, and in my opinion, the best city in Sweden. But if you ask Anders, he'll probably disagree with me because he's from Stockholm. And so my family came to Sweden when I was around 3. My parents fled the civil war in Somalia. And so I grew up in Sweden in a typically large Somali household. I then trained as a dentist and I worked in Sweden. And then after that, I went off to Oslo and I co-led a private practice that became hugely successful. And I think it was around that time that I became very interested in why diseases were apparent in some pockets of the population, often people with non-ethnic Scandinavian background. And during my uni years, health was described as the mere absence of illness. So we never discussed how health was intertwined with social determinants. So I ventured off and got some training in public health, and my career really took off in public health during 2015's migrant crisis in Europe. And I saw myself supporting the municipality of Oslo in dealing with the influx of migrants. And then fast forward in 2019, I was seconded by the Swedish government to the Ministry of Health Development in Somaliland in a capacity building effort. And I would say the rest is history. I'm now a permanent staff member at the ministry. I serve today as a senior technical advisor to the Director General. And it's in that role that I often see myself negotiating with partners, stakeholders. And so for me, health diplomacy as an emerging global health leader from the global south, I think it represents an essential tool for advocating for equitable access for health resources, influencing global health policy, ensuring that the unique challenges that face low and middle income countries are addressed at the international stage. It's a way to engage with global power structures and negotiate partnerships that benefits the region, helping to address disparities in health systems, financing, but also access to medical innovations, like Jimmy Colker was now explaining. So what are some of the tools and tricks that I use when I go into negotiations? And just a disclaimer, I'm not an expert, I'm still learning, and you probably heard of these tools and tricks and used them before, but I think for the interest of my talk today, I'm going to maybe share how I've shaped them into something useful for my reality and the context that I work in. And I think the first one that's very obvious, and I think Anders mentioned earlier, it's about building relationships. It's fundamental, and I think you have to have that foundation to build on negotiations. Your opponent needs to know about you, and if they don't know you on a personal level, your reputation must speak for you. And you also need to understand your opponent and network. Give time to learn and get to learn people. And it's not merely sufficient, as just Jimmy Colker was mentioning, that when you go into negotiation that you have the technical skills, such as the statistical numbers or a narrative of a story. Instead, your interpersonal skills, your abilities to read the room, your willingness to understand your counterpart and their position is very invaluable. And I think sometimes we underestimate the importance of, like Anders was saying, dinner diplomacy or corridor diplomacy, networking, looking for commonalities, because I think we as humans, we're more alike than we might think. I think also, in the Swedish culture, when we network, we always start discussing the weather. Everyone has an opinion about the weather, and it's always horrible weather. But I would actually say, try to be bold and brave and become a bit personal, but remain professional. And if you find that sweet spot, that can be very, very powerful. I think the second aspect that I would want to bring is to try to understand your context in the wider context and then use your contextual strength. And what do I mean by that? Well, no one knows, for example, Somaliland the way I do in negotiations. Yet again, Somaliland needs to be contextualized in the broader context, and it needs to be made relatable. So although you're negotiating for national interest, you need to make those national interests and build a case for regional and global interest at the same time. And I think the saying local is the new global is very befitting here. A prime example is also what Jimmy Colker now explained is we spoke also about the late Kofi Annan, but how he managed to build a case around HIV/AIDS being a global health security issue rather than merely a disease killing Africans. So to give a glimmer into the context or maybe the ecosystem in which I operate, I'm in Somaliland. It's a de facto state in a geopolitically complex area of the world. While on one hand, Somaliland is very entangled with Somalia, on the other hand, it's made enormous progress in peace building and rebuilding institutions for being a semi-autonomous state. And for those of you that are following foreign politics at the moment, the Red Sea and Somaliland in particular has become increasingly attractive for superpowers such as the United States, the UK, Russia, and China, but also the Middle East, because Somaliland is well situated and it has a direct access and the longest coast facing the Red Sea. We're also faced and surrounded by horrendous armed conflicts, protracted wars, humanitarian crises, whether that is across the Red Sea in the Middle East, or east to Somaliland in Sudan, or even centrally in Congo. And apart from that, Somaliland is also situated in Africa, a continent that has been struggling with significant health issues, such as infectious diseases, emerging pandemics, currently the Mpox and the Marburg virus in Rwanda, a rise of non-communicable diseases due to the changes in lifestyle, but also challenges related to health infrastructure, access to medicine, and health financing. So while negotiating for local needs, you have to remember the context that surrounds you and the politics that shapes your context. I think for the third part and the third point, and this is something really dear to my heart, and I still struggle with that, it's really important to maintain dignity throughout negotiations. And why do I say that? Well, when you represent a low-income country, it requires resilience and strategic thinking, especially, for instance, in Somaliland, when approximately 90% of our healthcare expenditures depends on external funding. This reliance places us in a very vulnerable position where shifts in the aid landscape could severely impact the health of Somaliland's population. However, I try to, when I go into these negotiations, to not approach it from a position of weakness or with a mindset of dependency, because it's important to remember that aid is not just charity, it's a form of influence. Wealthy nations seek to extend their power and maintain their relevance in Africa. And so therefore, despite the disparities in resources, I remain confident that our partnership is mutually beneficial. So to maintain dignity is crucial because their interest actually lies in continuing the support. Another pressing challenge is the growing humanitarian crisis that I just described due to the armed conflicts. And it creates an intense competition for very scarce resources. So in this context of Somaliland, where humanitarian crises are unfortunately endemic and climate change is disproportionately affecting the populations here, we're faced with a very harsh reality. How do I go into negotiation where I convey the plight of my people in a way that preserves dignity and does not reduce their suffering to competition? I think it's essential to resist the temptation. I think in psychology, they call it comparative suffering. And it could be a trap where we try to measure our challenges against others. I think what we need to do is to present the case of Somaliland with clarity and empathy, but also focus on the unique needs of our population without diminishing the struggles of others. By doing so, we ensure that our advocacy and our diplomacy is both respectful and effective in securing the necessary funds. I think for my fourth point, I would say as a negotiator and also as a leader, use your superpower. The world is increasingly changing. I think it's significantly different from when you, Anders, or even Jimmy, when you were out in the world and being diplomats, although Jimmy, you might still be one. It's a new world, and the challenges of today are wicked in nature. Today's world looks like me. Most of the world's population, they reside in low and middle income countries. For instance, many of them speak besides English, I think one of the main languages are Mandarin, Hindi, Arabic. We're becoming extremely globalized. And I think as a diaspora, I think Lindsay was mentioning that in her training, she had something called diaspora policy, I think, if I'm not mistaken. And I think as a diaspora returnee, I think I've embraced the strength that lies in diversity and inclusivity, because people like myself are putting global back to global health. We have this unique firsthand experience with having one leg in the global north and the other leg in the global south. And I think that gives me an understanding of both standpoints on each side of the negotiation table. And I think that's why I also want to commend Anders and others on the call today for creating a global network of health diplomats where diverse points of views are the centerpiece of that work. And then I think lastly, what I've seen quite powerful in my setting and when we enter negotiations is to negotiate as a team. There is power in number and unity. And I think a prime example is Africa CDC, because what they managed to do was to unite the voices of African heads of states and the ministries of health. And that became powerful, especially during the COVID-19 pandemic. And so as for our team, what we're trying to do is that we mix senior but also emerging leaders, men and women, when we negotiate, because representation in today's world is key. And it sends a clear message also to our opponents that we stand united in our negotiation objectives. I think just a last reflection for me, I think as an emerging leader, is that I'm really grateful for the opportunity to take part in fellowships such as the Kofi Annan Global Health Leadership Program, but also the executive course in Diplomacy and Politics for Health, to learn from senior professionals such as Jimmy Colker in health diplomacy, and to share experiences. I think particularly in a time when the world is becoming increasingly polarized, while the challenges we are faced with require unity. So I think as I progress in my career, hopefully in global health, I'm eager to engage with this kind of network, but also pursue future training opportunities for emerging leaders, because I think there's also always new skills and strategies to learn and add to your toolbox. And as you mentioned, Anders, I'm particularly looking forward actually to contribute even in a small capacity to the Africa-based regional and global health diplomacy initiative that is being currently in the development phase by African universities, but also institutions such as Africa CDC and Karolinska Institute. And I think initiatives like that will shape the future of health diplomats on the continent. And it's going to be a very exciting journey to be on that. Thank you.
Amal, thank you so very, very much. I'm deeply impressed, and I should apologize. I don't think you're an emerging leader. You are a leader. Before having a question to you, I'd like to hear just Jimmy's reflection after having listened to Amal. What's your reflection having heard Amal speaking?
Well, I certainly agree with you that she doesn't, I don't think there's any apprenticeship there. I think she's representing a point of view that's absolutely right, and she will be a formidable negotiator for any government or interest that she's representing, because she's got it right. She's understanding that these are relationships based on trust, on respect, on putting forward your best case and listening, and that the old-fashioned power dynamic of those relationships is a trap, and that if we are relying on that, and a couple of the comments in the chat have, I think, made the same point, that if we're relying on a power dynamic of saying that the people with the money or with the expertise of a generation ago are the ones who are going to prevail on that basis, we're fools, because we are no longer in the global north the majority. We are no longer the ones making decisions for governments or for populations in the global south. And that unless you, Amal, your generation, and the people that you're speaking for are at the table and are making these decisions, examining your own priorities, and then presenting them cogently to partners who actually can advance your agendas. I don't think that the idea is that everyone should go it alone. I think there are genuine advantages that people like the United States, institutions in the United States, can present to governments, people, institutions, organizations in Africa. The US and Sweden can be valuable partners, but not on the basis that it's going to be a decision that we've decided in a congressional budget line is what's good for Africa, and therefore we're going to come to Somaliland or to any other country and just implement that decision kind of blindly or without figuring out what the actual needs and perspectives of the local people are.
Thank you, Jimmy. Your reflection was much more ambitious than mine. When I was listening to you, Amal, my reflection was that, okay, it's time to retire. But I had two questions for you. Because there was a couple of things you said about, of course, about the dignity, the respect, extremely, I think, important skills. But you also said something about being personal, but yet professional. Can you say a few more words about what that means? What is that? How do you do that?
Well, I think that's a very great question. I think it's the small subtle things. You pick up things in meetings, you know, your interpersonal skills, you read the room, you find commonalities in what people are saying. And it could be that what they said in that meeting kind of resonated with you. And so off camera, you know, off the boardroom, you can maybe connect on that. And like I said, you know, we're more alike than we think. We're all coming into these meetings with our titles and our agendas. But at the end of the day, what we want is we want to achieve the same thing. The goal is to try to support countries such as like mine to develop, to have populations that could prosper and be healthy. It's just maybe finding the means of doing that together. And so that's why I said it's really important to be vulnerable and do try to open up and share some of your thoughts that you have, but also maintaining professional at the same time. And it's a very fine line, but when you do get that fine line and you can do that, it's a very powerful skill that I've been able to use when negotiating.
Now I lost my camera. Now I'm upside down. Okay, I'm here somewhere. I'll see whether I can get that back. I was running out of battery. My other question is, because I think people would open up for questions before we end. But I think quite a few people, having listened to you, also are sort of thinking, what are you going to do in the future?
Are you asking me or Jimmy?
Yes. No, you. Not
Okay.
Jimmy. No.
Very good question. I don't know, but I do feel like the kind of work that I'm doing is meaningful. It gives me purpose. I'm also in a very unique position that whatever we're able to negotiate, I can actually go to the field and see it being implemented. And just to have that, you know, closeness to what you've been trying to negotiate behind the scenes for a very long time is, I think, it's extremely powerful. I also think, you know, I'm open definitely to explore other environments and looking at how can we better the health and lives of populations around Africa. But I think my heart very much lies in low and middle income countries. But again, like I said, we need to put global back in global health, and global north and global south really need each other to, you know, work towards that goal. So I'm not sure, maybe if you're offering me a global health ambassador role in the future in Sweden, I might take that role. So let's see, Anders.
Okay, very good. I'm trying to get back my video. Open up for questions. Do we have any questions from participants? Raise your hand, please. Now I'll see whether I can get back my camera.
Hello? Yes, can you hear me?
Yes, please.
Perfect. So Dr. Alberto Martinez again here, mostly with a humanitarian experience in the field. So I have just three points. The first one is a question. Being a consortium of universities, is there any of the programs that are involved with other schools locally? For example, the London School of Hygiene and Tropical Medicine has a joint program with the London School of Economics about public policy planning and financing, because it's not only about how to engage with the external actors, but also how to understand the internal politics, let's say, that happen within countries, within you know, offices, even. So I think that's important, and also in my case, also biomedicals, how to engage with the others. You know, with the law, how to engage with the judiciary, all that. So that's the first question. A question. Then, yeah, for Ambassador Jimmy Colker, that was a great experience sharing. Thank you very much. For me, I've been working, for most experience, the bottom of type of diplomacy, of health diplomacy. And actually, we do it on a daily basis, where we have to negotiate access, right, with certain groups, but where we also have to negotiate with governments, with Ministry of Health, which are themselves tied by higher policies, for example, by the USAID, so to say, in, I don't know, reproductive rights, just one example. And that us as humanitarian medical organizations have to convince, lobby, fight. That's what I was putting in my former question: how to fight for causes that go beyond giving us purpose in our work, but actually looking at all times for the patient's rights. So yeah, that's kind of the thing. And in this context,
Alberto, can you make your question a little bit more to the point so we understand the question? I didn't fully understand what the question was.
Sure. The question is, the programs that are taught, do they include all the aspects? Corruption, which is very, very high in all those African countries. Aid-dependent countries like Sierra Leone, which I was working 6 months ago, all aid-dependent. They couldn't do anything without it. Their hands were tied. So how to do that? How to learn how to do that? For us mortals, even if you get to work in the government, what is the reach of the global health diplomacy in transforming lives? And lastly, I would say that that local is now the new global, but local has always been the local. And local has always been either the object of study for academics, the object of action for NGOs, for example, the object of interest for foreign policymakers, or I don't know, for churches, the object of their spreading of their message. So local has always been the interest of global.
You're breaking up.
Thank you very much.
I have difficulties following you 100%. But we have a couple more questions, but let's hear Amal, any reflection. Could you hear what Alberto was asking?
Not really. I think he was breaking up there in the end when he was making reference to local is the new global. So I no, I'm sorry, no.
Let me try, because he did the middle question. I think responds also to the point that Keith Martin made in the chat, that what are the other inputs that affect policy decisions and policy choices. And I think he was enumerating a couple of those, that there's no question that an American diplomat or aid representative clearly is representing the American people first and foremost, that it's a complex political process that would result in policies with regard, which that ambassador or that person working in the field would need to be conscious of and represent. And therefore, the entire list of things that the country or that the partner might want to do might not be seen as in America's interest, or might not be acceptable to the Congress or to the administration at the time, or to the budget terms under which the grant or the the cooperative agreement is set. And certainly corruption is a huge factor, and we are very conscious of setting up conditions which are sometimes uncomfortable for partners, of accountability, of oversight, that undermine what Amal Ali rightly said are the preconditions of trust, that for these relationships really to be optimized, we need to trust each other. We need to recognize the value of what the other side is doing. But because there have been examples of corruption, of misuse of funds, of not respecting the other side's interest, we put in all of these guardrails, and those, if they're not respected, if they're not properly explained, if they're misused, can undermine that trust and can make the agreements perhaps less likely to succeed. So you raise good points, and these are, as Keith calls them, inputs that affect not just our decisions, but our ability to be most effective.
Just on the first dimension of what you commented on Jimmy, in terms of, let's see, am I muted? No, I'm not. In terms of national interest and politics, I mean, I think that's part of reality, that different countries have different interests. And that was a little bit what I was I mean, beginning to speak about before, or asking you about before, whether there is a conflict here in between politics and evidence. And we have different, I would say, interpretation or of evidence, and we use evidence in different ways for political purposes. Different governments do that. And I think that's also part of reality. And I think that, I mean, in some way, we must both accept, even embrace that that is part of health diplomacy, that we have governments, we have stakeholders with different interests. If we have a private sector company here, we have a civil society organization here, we have one government here, one government here, they have different interests. They are all referring to evidence, but we have different interests. And of course, the art here is to see how can we then basically, and my only is my sort of definition of health diplomacy is that, yes, the interest is to improve the health of people.
Right.
That is the overarching objective. And if I can use that in some way as a wedge in order to be able to make progress, I think that's a possible way forward. But
and one aspect of local,
one needs to accept in some way, of course, recognize that we have different interests.
Right. And one aspect of local is the new global is that social determinants of health are so important. Yeah. And that while we can have evidence that some communities within a country are performing very poorly, perhaps their health outcomes are not good or don't look like our investments are paying off, it could be something that doesn't have to do with the investments themselves, but other social, economic, political determinants of health that are influencing those results. And so a knowledge of local circumstances and ability to work with partners to address not just the evidence, but what may be producing some of that evidence.
A question from Netzanet. See whether we have you with us.
Yeah, thank you again. I hope you can hear me.
Yeah.
All right, thanks. So, yeah, I fully agree with what Aman has been saying, with all the ideas. It was a wonderful presentation as well. And Dr. Jimmy, was also a privilege to attend your session. And the question probably goes to Dr. Jimmy, if because this is always into my mind, how we can support or we can help, because this is when we come to global health, we come to the discovery of drugs, the discovery of vaccines, and they should go through a clinical trial. So whenever there's a clinical trial, there are a group of people whereby these trials should first be done. And however, once the discovery has been done, if the intellectual property goes to somebody who has been leading this research, these projects, but the people who have been investing their lives or investing their time and money have been forgotten in most of the cases. And I don't know how the global health or the global health diplomacy can treat such kinds of situations, how to help those people who participated in the clinical trial and who contributed the best in the global health interventions. And if you can reflect on this, I'll be happy. Thank you.
In some way, I think this goes back also to what you spoke about, Amal, about dignity, respect, and in some way, I mean, the ethical values here. We have spoken a lot about that if you are going to be successful, it's not that some of us believe that ethical values are important and that certain ethical values are even more important than others. But I would say, based on my personal experience, it's also useful or not useful, but it's important to be successful. If you're honest with yourself and you have clear ethical values and you're prepared to respect people, I mean, that helps you in the work. So in some way, what you're speaking about here about clinical trials and who are part of those and how do you respect those, at least for me, that has to do with when you're going to go into a discussion about how the results are used from clinical trials, etc., and who will have access to the results and the outcomes of the clinical trials, all of this has to do with the respect for people. And you need to have a clear sort of, I would say, yeah, what's the English word? Compass. Amal, help me with that.
Like direction.
Yeah, direction for
Yeah.
how you are navigating your work.
Yeah, and I agree with you. Maybe I can expand a little bit on what you just raised. I think it's very important that the government plays its role. And the reason why I say that is that there has to be checks and balances. External researchers can't parachute into Africa and just collect data and use locals to test their drugs on. That's we're living in 2024. That's not acceptable anymore. And I think that goes back to, I think also what Jimmy said before, that there has to be some agreements signed. There has to be regulations in place. For instance, from my experience, what we do is that we have researchers that collaborate with us, but it goes through a very rigorous process. It goes through an ethical board. We talk about data ownership. We talk about who's going to use the data, the involvement, and the rights of those data properties. So I think, obviously, of course, health diplomacy can play a role, but I think that goes back to what kind of checks and balances do you have in the country? And going into, where we are today, into the future, the way I see it is that it's unacceptable. And it's interesting to hear that from your experience, that we're still faced with some parts of the world where that is still apparent. But yeah, there are regulations in place, and they are actually quite global at the moment. When you talk to academics right now in anywhere you go, they talk about the importance of respecting individuals and that you conduct your research ethically. Maybe Jimmy, you want to add something to that? I think the question was directed to you initially.
The clinical trial, there's a lot of attention being paid to clinical trials, and there are networks both involving research pharmaceutical companies, involving some of the bio companies and ethicists and others, because the situation you describe, Amal, was sadly the case before, and that the companies that wanted to get the drugs to market the most quickly realized that to get the FDA approval, if you didn't have the complications of women of reproductive age, if you didn't have to worry about pediatric formulations or how you would deal with adolescents or children, you could get the approval for the drug, get the highest priced developed country markets for those drugs, and then worry afterwards about the people who might actually need them the most or be in poor countries and so on. And the question of where these trials were held under, whose rules and who benefited from the results of those trials was a kind of colonial relic, or a relic of a system which was, from many points of view, exploitative. I think we're beyond the worst aspects of that, but we don't have a brand new system in place of what is fair, who should be in charge of this, what are the roles of multilateral organizations, of national governments, of industry standards themselves, of the regulatory authorities, what's an acceptable clinical trial, how long should it take? And then we had examples with Ebola, for understandable reasons, that drugs were given experimental permission to be used in COVID as well, that didn't go through a normal clinical trial process because the need was so great. And we were seeing if there was a promising vaccine or a therapeutic, they said, well, let's give emergency use authorization for that. And almost everything that was used to treat COVID was under emergency use authorization. So the whole system, I think, is undergoing a kind of rethinking. And I don't, as a policymaker, have the answer, but we do need the best scientific minds to tell us, how do we analyze this risk? What are these risks? We clearly want to help people who are suffering, save as many lives as possible, move as quickly as we can, not put unreasonable burdens on the developers. And the research part is pretty good. The D part of R&D is very complicated, very much connected to who's going to have the rights to make a huge profit on some materials, who's going to have the intellectual property and the right to distribute such things and to get future benefits from them, determine who has access to them. And this is, of course, being negotiated now in Geneva. It's being negotiated individually in many, many individual cases of access to high-priced medicines. There's some in the AIDS world now where I gather there was an encouraging announcement today of generic formulations of this new drug that looks so promising in preventing HIV. But there is not a gold standard yet of how we're going to figure out what to do with the results of clinical trials like that one, which are so promising, so clearly in the benefit of humankind, that those drugs be widely available. But who's in charge? Who's in charge here to make that happen? We don't know. That's your generation's responsibility, and I hope success.
Big thank you to all of you, to Lindsay, to Gary, to Amal, to Jimmy and Paul who contributed, and to all of you who listened to us and took part of this and also were part of the discussion. I mean, it gives me hope that there is an interest, not just for public health, not just for global health, but also to have an interest in this sort of political environment. How do we navigate in that? And this, I would say, is a science in itself, political science. So if you have an interest in this, look for opportunities. And many of you have already looked and asked, how can I be part of those programs? There are opportunities, either which are called global health diplomacy or courses in political science. Some of the tools that are taught when it comes to political science are also extremely useful to have if you're going to work in health in different ways at the national, regional, or global level. So a big thank you, and especially big thank you to the Consortium of Universities for Global Health who organized this. Sarah, thank you very much. Keith, for being behind all of this. A big thank you, and hope we will see each other in one way or the other somewhere across the world. So a big thank you to all. Thank you.